I welcome everyone to our first Newton Grant online seminar. And the title of the seminar is A Betterment in Stroke Caregiving During COVID-19 Pandemic, from Manual to Modern Apps Technology. So today, afternoon or evening, depending where you are, or morning, depending where you are, we are lucky to have 4 speakers from various backgrounds, not only from Malaysia, but also from the United Kingdom. We are aware that how early the time is for them now. I hope they have drunk their hot coffee and they are wide awake. Which we are so grateful for their participation, regardless in the difference in the time zone. So without further ado, it's my honor to delightfully introduce the audience to the speakers. So I will introduce the speakers first, and then it'll be easier so that if they want to talk longer with their PowerPoint slide, it'll be much better. Our first speaker is no other than our USM son, a very old son, 33 years old, okay. High-spirited graduate student, Dr. Muhammad Iqbal bin Mukhti. He graduated from School of Medical Sciences in 2013. He's such a baby, from USM compared to me, 1986. Okay, and had done his latest service as a medical officer in the Ministry of Health in PKD Pasir Mas. Last year, before pursuing his masteral study in 2020 under public health. As a very eager young man, he chose to continue his study in the next doctorate level of public health under specialty of family health, which he has his passion and interest the most. The seniors, and I, the senior of him, have always wished him good luck and supported his education journey all along. And for today, he will share with us his great findings from his most current research work. The second speaker is Dr. Suresh Kumar Kamalakannan, PhD. He's the Associate Professor of Public Health Foundation of India and Research Fellow for International Centre for Evidence in Disability, London School of Hygiene and Tropical Medicine. You can see the very handsome guy there on the screen, smiling away with the giraffes at the back, I think, on his wall. As an academic researcher with expertise in occupational therapy, public health, disability, and epidemiology, he has had his early career as a fellow in clinical and public health for DBT, Wellcome Trust India Alliance, evaluating the effectiveness of a technology-enabled educational intervention for stroke survivors in India through a clinical trial. Currently, he's one of the co-investigators for a project funded by MRC UK to develop a stroke caregiver intervention for strengthening the health system in Malaysia. Thank you very much, Suresh. With USM and also the NIHR funded research related to promoting university health coverage for stroke survivors in South Africa. Next, I would like to introduce Dr. Daryani Darus, Head of Department and Rehabilitation Medicine Physician from our neighbor hospital, HRPZ, because I'm an old guy, so I'll just keep calling it Hospital Kota Baru, you know. Serving for the dedicated department since 2015 after graduating as a medical doctor from Universiti Kebangsaan Malaysia and later from Universiti Malaya with a Masters of Rehabilitation Medicine. We are also grateful to have her not just as our speaker today, but also as one of our important co-investigators for our research project. Her experience and specialty as a rehab physician includes amputee, cardiac, neuromedical, pediatric, spine, and stroke rehabilitation, as well in social evaluation and many more. Dr. Daryani also was a recipient for the Excellent Service Award for the year 2002 and 2018. Our last but very important speaker, Dr. Iliatha Papachristou Nadal, was a research fellow and project manager for Institute of Psychiatry, King's College London, and later joined London School of Hygiene and Tropical Medicine UK in 2018 as the assistant professor. experience as a research psychologist for RCT in her early career step, she has now widened her research field to developing and evaluating behavior interventions with lower and middle income countries with diabetes and stroke care. Along with Dr. Suresh, Dr. Iliatha is also one of the co-investigators for our Newton-Ungku Research Fund Malaysia-UK collaboration project. So here you are, 4 very important speakers who will be spending their time talking in a few minutes' time, up to 7:50 a.m. their time maybe, or is it p.m. our time? Yes, p.m. our time, 3:50 p.m. our time. And then hopefully by 4:30, if all of us are on time, we will open the discussion to panels and participants to discuss this important topic. And I think it's very important because as a neurosurgeon and looking after patients for the last 27 years, we can do fantastic surgery, bypass, all sorts of interesting drugs are now being used to treat strokes. And then these patients have to leave the hospital and they have to go back to the community. And like a state in Kelantan, we don't have many neurologists and they're just too busy to be able to follow up the patients in the community. And I think it's about time, family medicine physicians, public health physicians, and other physicians also take part in the treatment of these patients, including the rehab physician, because now we're trying to see whether these apps that we can make will be able to help the community, especially the poor caregivers and their patients, to overcome their trips. Because to come to our hospital, a patient who cannot afford a car, or may only be able to afford a bicycle or motorbike, has to spend about 60 to 100 ringgit one way. And they have to rent the whole taxi or the whole van to come to our hospital. And so in one day, they lose about 12 hours. They lose about 200 to 300 ringgit just for travel and a little bit of food, just to spend 15 minutes with the doctors in the clinic. What a shame. So I think there must be something better that we can do for the caregivers, for the patients outside there in the community, regardless if they are poor, regardless if they are super rich, and we don't have many super rich patients in this state. And I hope that the talks by Dr. Iqbal, Suresh, Daryani, and Iliatha will be able to give us ideas to help improve further. And maybe even other grants will come out from this presentation today by the participants who are even not associated with the Ungku Newton grant, and who may be able to improve the quality of care of our stroke patients when they leave the hospital. Thank you very much. So I would like now to invite Dr. Muhammad Iqbal Mukhti to give his talk on the pandemic caregivers' experiences and coping strategies. Dr. Iqbal.
Thank you to Mr. Chairman, Prof. Dato, Dr. Jafri Malin. Assalamualaikum and very good afternoon to speakers and all distinguished guests. So first and foremost, I would like to thank for giving me this opportunity to share with all of you on our current progress of research publication around the corner. Within this precious only 5 minutes given by the organizer, I will try my best to simplify and briefly explain on what our research was all about as an eyes opening to our actual event today. So for your information, this research was ethically approved by Human Research Ethics Committee USM, as well as a Medical Research and Ethics Committee MREC MOH Malaysia, in collaboration with the London School of Hygiene and Tropical Medicine. This research granted underneath a big umbrellas fund, a Newton-Ungku Omar USM fund. We'd like to let you know that we managed to successfully conduct a research entitled of exploring the lived experiences and coping strategies of stroke family caregivers during the COVID-19 pandemic in Malaysia. So, along with the stroke as a global burden, second most leading cause of early death in 2016, and similarly to be expected in 2040, second largest cause of death in 2016, and similar rank in a recent report 2019. As for Malaysia, the mortality rate secondary to the stroke was increasing in trend from 2010 to 2016, with stroke placed as third most premature death 2017. And third most common cause of death in 2019. Now, narrowing down to the local context of Kelantan State in Malaysia, the prevalence of 0.5% reported in accordance to NHMS 2011, with the placement at fourth among the other states in Malaysia based on the local study conducted in 2020. As we know that the global pandemic was officially announced on March 11, 2020, Malaysia was proactively taking the control measure by executing Movement Control Order MCO subsequently on 18 March in 2020. Nevertheless, this control measure was effectively curb the chain of transmission, as shown by many studies subsequently. It was also significantly impacted the stroke caregiving and limited the rehabilitation process and also the treatment process. So it encompasses on the logistic issue, the perception, the health-seeking behavior, the financial constraint, the health care services in modification, psychological and physical effect, not only to the caregiver, not only to the stroke survivors, but also to the caregivers. So therefore, throughout in-depth of these study findings, it helped us to clarify the fundamental issues, pinpoint the strategies that assist the sustainability and functionality of the stroke healthcare services. So therefore, come to our objectives to explore the burden and experiences faced by the stroke family caregivers, and also to explore the coping strategies during the pandemic COVID-19. So basically, the study designed it as purely a qualitative research with phenomenological approach conducted from November last year till June this year, 2021, involving the family caregivers in managing stroke patients who registered under HUSM and HRPZ2 who fulfill all these listed inclusion and exclusion criteria to be selected. Whereas as for the sampling, we were using maximum variation or heterogeneous purposive sampling method. So as for the result, all of these 13 respondents were well projected from a variety of respondents. Three teams were derived on the experiences that were worsening of the pre-existing issues, the emerging of the new issues, and more interesting, not only from the negative side, but also the positive impact during the pandemic, as represented by the fewer burdens and challenges team. So the worsening of pre-existing issue was best explained by three sub-themes encompass of the defective social life, the formal duty becoming more burdened with the pandemic, and also the appointment schedule that becoming more tightened as compared than before. As for the emerging new issues team, 6 sub-themes were derived to explain, include defective in daily mobility, the changes or the modification made by the healthcare services during the pandemic, the limitation faced by the caregivers to follow the strict SOP, the extra role in the patient care, especially to taking care, the extra precaution on the patient's hygiene and therapist schedule while at home, the constraints faced by the supportive person, and the lastly, that explain and illustrate this theme was about financial constraint, not include the limited household income affected during the pandemic COVID-19, but also the extra expenses and the costly items priced during this pandemic. As for the positive impacts represented by the fewer burdens and challenges, team will explain through the improvement in hospital logistic issues, particularly on the availability of the parking lots with less visited during the pandemic, and as well as the strengthening of the family bonding sub-team, especially with more time spending at home while in pandemic. So coming up to the coping strategies, two themes were derived, including of problem-focused engagement and also emotion-focused engagement. Problem-focused engagement was explained by three sub-themes that were caregivers attempted to adapt with any available support that they can get during the pandemic. The adaptation as well made by the caregivers towards the changes made by the healthcare services, and also the initiative taken to get permission to mobilize during the pandemic, even with the hardship. So the second theme that reflect on the coping strategies was illustrated by the acceptance of the caregivers, or the evidence of the caregivers at last to the strict SOP of the new norms, and also the passive response of the caregivers towards the burden and challenges of the caregiving as they passing through on the past. So as a conclusion, the problem raised during this pandemic could be eased by having an integrated healthcare system involve all the parties. And the main priority here is to put the sustainability of care even during the health crisis. The communication between all the stakeholders and family caregivers should be in place and effectively managed to reduce the bureaucracy and fasten the process. And last but not least, we would like to urge the efforts to emphasize the consistent use, the widespread use of the telehealth in the healthcare system to overcome the issues raised during the crisis. So by that, I end my presentation. Goes back to Prof. Dato. Floor is yours. Thank you.
Thank you very much, Dr. Muhammad Iqbal. All questions and discussions will be kept till the end at 4:30. So without wasting much more time, I would like to invite Dr. Suresh Kumar to give his talk titled Care for Stroke, a Home-Based Web-Enabled Intervention. Dr. Kumar, the floor is yours.
Thank you, Professor Jafri, and thank you also for the generous introduction. I'll just try sharing my screen. Is my screen visible?
Yes, I can see the title of the slide. Yes.
Let's check whether it's moving. Is it moving now?
Yes, it is.
Superb. Okay. Thank you so much again. So a warm greetings to you all. Very good evening for those who are attending this conference from Malaysia, and also a very early good morning to collaborators.
Dr. Suresh, can you come closer to the microphone?
Can you hear me now?
Can you speak loud, maybe closer to the microphone, because your voice is faint.
Volume is full. I'm using my headphones on, so hopefully you should be able to hear me a little better now.
Okay, go ahead. Yeah, better.
Sure, thanks. Sorry, couldn't. Are you able to see my slides now?
Not yet. Yes, we can see your slides.
Yeah, so I would like to extend my warm greetings and also, first of all, thank the funders, supporters, and collaborators from Malaysia and the UK for providing us with this opportunity. Talk to you all about the care for stroke, especially in in my experience from India. So I'm going to talk to you all about Care for Stroke, which is a M-Health innovation to kind of manage post-stroke disabilities and provide post-stroke rehabilitation in a setting like India. I'll share how I developed this intervention and where I have come across with this intervention currently. To provide you all with the overall kind of burden that we have related to stroke, as you can see from the slide, we have in among the top 10 causes of death that is displayed on the right hand side in the figure from the global burden of disease study estimates, we can obviously see that stroke remains the second leading cause of death in the whole world for the past 40 years. And the left hand side, if you look at the proportion of the leading causes of disability adjusted life years in developed as well as developing countries, stroke remains the third leading cause in terms of contributing to the disabilities worldwide, both in terms of if you look at the developed countries context as well as the developing countries context. So this is to reiterate that stroke is one of the leading cause of death and disability worldwide, and it's been the same, though the rank is number 2 and number 3 in terms of mortality and morbidity. The number of cases or the prevalence and incidence and increase in the disability adjusted life years every year contributed by stroke is been massive, and especially in the low and middle income countries context. When you look at what are the contextual barriers for rehabilitation or provision of stroke care for people affected by stroke, as well as their caregivers in a context like India, which is more or less very similar to Malaysia, you see all these 4 reasons very, very prominent in a country like India. So the country has definitely is experiencing lack of policy initiatives, especially in relation to rehabilitation. So we do have lots of good policies related to health. We also have a national policy for stroke and all the other non-communicable disease policies. But when you look at provision of rehabilitation services for people with disability in general, let alone stroke, it is lacking. We do have lack of resources for rehabilitation, meaning the number of rehabilitation professionals like occupational therapists, speech language therapists, audiologists, social workers, and prosthetists and orthotists, they are all very less in number. Given that the country is the second largest populous country in the world, we have very, very little amount of resources predominantly accumulated in urban areas rather than the entire country. And we do have issues in relation to technology. We do call ourselves as the IT capital for the world. However, when it comes to application of technology for health, we still lack resources. Financial allocation in relation to health and social care is also very, very little when it comes to provision of social care and social security for people with disabilities in general. We do have architectural barriers. So there are lots of places, including government building, which are not accessible by anyone with disability in general. And more predominantly is this issue of stigma. So it's not just the environment, it is not just the policy and the system and resources we have. We do have social stigma as a biggest barrier in terms of the context. So people with stroke, somebody who's walking with one-sided paralysis, they would be actually looked at as someone who cannot contribute and become economically productive in the community still. So given this context, I was looking at what could improve the access to stroke rehabilitation services in India. When I thought about this particular aspect, improving access to stroke rehabilitation in India, I started off with what existed first in the country. And we look at the points on the left-hand side. We do have hospital-based services in India, which are predominantly provided by private health sector. And so we do have government systems, but for stroke care or stroke rehabilitation, we had hospital-based services only available. We do not have community-based services. We we have these services provided in private sector, which are considered very expensive compared to what we get in the government sector, which is absolutely free of cost. And these private hospitals and rehabilitation centers are available only in the urban settings. So they are not available in the rural regions of India, which contributes to about 60 to 70% of the entire country. And last but not least, it is the rehabilitation services that is available are predominantly run by or led by neurologists and physiotherapists. So this concept of multidisciplinary rehabilitation team and their services to somebody with stroke is not available in the country. And once I looked at what existed in the current situation, I was looking at what could change. And on the left hand side, if you could see, hospitals based services I thought could be converted to community or home based services. Expensive private care can be made less expensive by looking at options of providing that care through the government sector. Services that are available only in urban regions can also be looked at in terms of provision of services in rural areas as well, and then the services are widely available. And finally, when you look at service that is currently provided only by neurologists and physiotherapists, can be converted to a service that is multidisciplinary. It has got inputs from lots of people who are specialized in rehabilitation for provision of stroke care. And when I tried to club all these what could change concepts together, I identified three strategies. One is having an intervention that is community based primarily and educational in nature. So rather than actually straightforward getting into provision of rehabilitation services, looking at creating awareness about what happens when you get a stroke and how can you actually prevent another stroke or a recurrent stroke, as well as how you can manage your disabilities all by yourself or with or without help from your primary caregivers at home or the family members. And the last strategy was to look at what was surplus in the country. So we did have technology, and hence, rather than all the kind of deficiencies we had or the issues we had in terms of the barriers, technology was considered a strategy to be added to the other couple of strategies that I've explained here. And I thought an intervention could be developed systematically by combining or amalgamating these three strategies. So community-based intervention that is educational in nature, that could be used as a self-management or supported management intervention, and that could be driven by smartphone technology that's available in India. And that is the kind of combinations that led to the development of care for stroke intervention. So care for stroke intervention is very different to other interventions that have come up for provision of stroke rehabilitation services or stroke disability management services globally, because the intervention doesn't come from somebody who's experienced and who's prescribing that this is what must be provided to somebody affected by stroke. It is systematically developed, and as you can see, these are the four phases that has been kind of used in order to develop this intervention and ensure that the intervention becomes scalable in the future. So we have developed this intervention now. In the second phase, what we did was, after developing the intervention, we tried to field test it with a few participants and looked at the operational problems that we might have. Are there any problems in relation to smartphone technology? Can people access? Can people read what is there? Can people see the videos? And we kind of ensured that all their inputs are considered during the field testing, and the intervention was revised and a final draft of the intervention was made. The final draft of the intervention was pilot tested with a new set of 30 stroke survivors and their caregivers for a month to look at whether it is feasible and acceptable in a context like India to use care for stroke intervention. And once this was done, we are very happy to say that after finishing this, currently we are looking at evaluating this intervention for its clinical and cost effectiveness in the context of India through a randomized control trial. I'm just going to show you how rigorous we were in terms of developing this intervention. So I'm just talking about phase one, the blue colored row, where I'm talking about development of the intervention. And there are so many sub-objectives in order to develop this intervention. So the first thing we did was to understand the magnitude of the problem in terms of incidence and prevalence of stroke in India. And because there was no data, everybody was saying that the problem is more, but when you look at what exactly is the magnitude, there was no literature on it in an Indian context. Hence, a systematic review of the incidence and prevalence of stroke in India was undertaken. After that, we also wanted to look at global evidence for any intervention related to management of stroke at home. And we did not stop there by looking at just the evidence from the global community, because global community do have lots of evidence from the developed world or the high income countries on good interventions that can be provided in the community. However, we wanted to ensure that this is the same in low and middle income countries context as well. So we went to the patient's home, explored their needs, talked to people who provided stroke rehabilitation in the community, got an idea of what are the barriers and facilitators for providing stroke rehabilitation after hospital discharge. So this is the key term that drove the entire research. So everything was available within a hospital setting, but once the person with stroke gets medically stabilized in a hospital setting and he is discharged from the hospital, that is where the exact problem related to disability and rehabilitation starts. So we wanted to explore what are the barriers and facilitators for stroke rehabilitation, especially outside the hospital setting. And we did not stop there. We created a stakeholder group with lots of experts, including caregivers, stroke survivors, and people who provide care. We also had people who had the expertise in technology. We kind of introduced them to all the results that are there from the systematic reviews on the magnitude of the problem, on the evidence, and also on the needs, barriers, and facilitators. And they gave their inputs to decide on the best content for the intervention. So it is not me or my experience or somebody else's experience that is used for developing the intervention. We included a big team, an inclusive team with patients, caregivers, and experts, and they decided what should be the best content for the intervention. So they said how the intervention should be. It should be whether it should be videos or whether it should be cartoons, whether it should be in one language. Do you have more text in the screen, or you don't have to have any text? You should have only pictures and videos. So they gave us all the input, and whatever was suggested and recommended by the stakeholder team was used to develop the smartphone application as well as the intervention. And that is how the Care for Stroke intervention was developed. So if you can go to careforstroke.com, you can obviously look at the intervention from your end in real time. However, I would like to introduce you all to some of the key concepts that's there in the package. So we have 5 different components in this intervention. One section is completely related to information about stroke. It has got details related to warning signs of stroke, what are the causes, what are the effects, how you can prevent yourself from the stroke. And these are not textual characters or textual formats. These are people who are experts talking about their own problems and then providing you with a visual presentation of information related to stroke. The second section is related to exercises, because people with stroke always ask for some of the exercises that can make them walk back again and become as independent as possible. So we do have assisted and independent exercises that somebody with stroke can perform at home with supervision from the therapist that they are in charge for, and also the family members. We have a section on activities of daily living. Now this is something that's very niche in this intervention, and which may not be available globally, especially in terms of looking at the Indian context. The activities of daily living like brushing, grooming, bathing, toileting, dressing, if you look at wearing a sari or wearing say a lungi in the context of Malaysia and also in India, it's very similar. So those are the aspects that are looked at, and This particular section will help a stroke survivor and the caregiver to understand how you can become as independent as possible using single-handed techniques. Even if you're right-handed or left-handed, how you can wear a sari, how you can wear a dhoti, how you can eat on your own. All these details are available in this section. We also have sections related to functional skills, which is very important. It talks about how you can roll in the bed, how you can get up from the bed, how you can sit, how you can stand, and how you can walk. And finally, there is a section on assistive devices. And in this section, we have got locally manufacturable or locally fabricatable. So the stroke survivors and their family members, they themselves can access or kind of fabricate with the help of some people, including a cobbler, to come up with some devices that they can use on a day-to-day basis to become as independent as possible in their activities. So these are the 5 key sections, and each key sections will have 2 to 3 minutes videos. So we will have many 2 to 3 minutes videos, and that can be used by the stroke survivors and caregivers to understand what is possible and what is not possible for them to be doing at home to prevent themselves from disabling conditions because of their stroke. And when you look at this intervention, as you can see, it is a home-based intervention. You have a smartphone, you can use it anywhere in your home or even outside the home. So not necessarily you are going to meet somebody in a hospital setting, pay for them, and then get the information that you want. So it is a domiciliary intervention. It has got inputs from lots of stroke experts, including occupational therapists, physiotherapists, neurologists, physical medicine and rehabilitation specialists, social workers, prosthetists and orthotists, and people who are experts in advocating for disability as well. So it has got inputs from lots of people. It's purely educational in nature. We tell them to see it and then learn from it rather than stressing them to do what is there in the videos. And we very clearly inform them that do not practice whatever there is there in the videos without the guidance from a clinical therapist or a doctor, and also discuss with them before deciding on what you want to practice and what you do. Because it's available on the phone, it is in educational in nature with all the stroke rehabilitation professionals input. It can be used either by your own self if you have a minor or minor to moderate stroke, or you can get help from the caregivers to access the interventions from the smartphone if you have, say, major stroke or severe stroke. And finally, this is also a technology driven intervention where we use technology just to help people understand and educate themselves about managing stroke related disabilities, but we also have the facility to look back or track what is happening with them. So we can definitely go back to the data. We can generate lots of data to understand whether somebody is using the intervention or not, what is the duration for which the interventions are used, which content is actually seen a lot. So there are lots of research that can happen from the data that's generated and reports that's generated because the intervention is technology driven. And the other massive advantage is because it is technology driven and it's available on a smartphone or any communication media, anybody can look at it at any time they need at their discretion. So it's not necessarily that they should get an appointment, pay for it, wait for suggestions they want, and then ask right questions. So you can always go back and forth. You're free to access it, and it's available everywhere, not just in hospital settings that are available in urban areas, but even in rural villages. If you have phone and an internet connection, you will be able to access this information and will be able to understand how you can stroke related disabilities at any time. As I mentioned before, the first phase was development. The second phase was field testing of the intervention. So during field testing, we gave the intervention or the crudely developed intervention to few stroke survivors, and we identified key uncertainties like issues with connectivity. The video streaming was not happening because of the connectivity issues. Picture clarity was not there. The videos were not very clear for people to see what is happening there. Quality of the videos were not great. The functionality of the applications, how you can touch the smartphone to access these videos, All these were having issues, and those issues were identified in the field testing. After identification of those issues, the intervention was reviewed, revised, and finalized. Once the intervention was finalized, it was submitted back to the stakeholder team, and once they approved the revised content, the intervention was pilot tested for its feasibility and acceptability. So we did identify all the operational issues, we clarified it, we sorted it out. And in the third phase of the development of intervention, we pilot tested the intervention for its feasibility. Can it be used in an Indian context? And also, do people who use it like it or accept it? So we identified those two parameters and evaluated that through the pilot testing of the intervention. And I'm very happy to say that the intervention was found feasible and acceptable. And all the participants we have recruited for the pilot study and to whom we gave the intervention free of cost. We gave the phone, we taught them how to use the intervention. We also gave them free internet connection and asked them to use the intervention for about a month. And we were surprised, actually, to be honest, to say that all the participants who were recruited used this intervention every day, at least for 5-10 minutes. So that was a massive kind of evidence to show that the intervention is acceptable and feasible. And when we looked at it through a survey, participants again rated the intervention to be excellent based on its overall credibility, usability, and usability. We had several publications of the systematic evaluation and development of care for stroke intervention. As you could see from the slide, we first also understood the challenges in understanding the epidemiology before even starting to look at the global burden. And then step by step, whatever I had initially said as some of the activities that we did to develop this intervention systematically, every activity is made into a paper, and it's all published in impact, open access, peer-reviewed journals, international ones. Currently, the intervention is being evaluated for its effectiveness in India through a randomized control trial. This trial is funded by the India Alliance, Wellcome Trust and Department of Biotechnology program. The intervention is also available in 4 different languages in India. So if you look at the Indian population in Malaysian context, if they have stroke and if they know about this intervention, there is a Tamil version for them. And people who can understand English, there is an English version for them to look at this intervention straight. Because it's India, our national language is Hindi, so we developed this intervention in Hindi as well. And the intervention is currently field tested in Hyderabad, which is a country which speaks, the population speaks Telugu there, so we have the intervention in Telugu as well. And when you look at improvisation, so this intervention is also being used or improvised with additional components such as speech language component, psychological component. It was focusing only on patients. Now we are trying to look at caregiver version also. We are looking at communication, cognition, even in terms of the way in which they use this information. So the intervention is currently smartphone based, but we are also looking at using virtual reality and sensors technology to enable more monitoring, more therapeutic component embedded in the intervention currently. So it's continuous process that's happening. When I look at the implications of this kind of interventions for future, I can definitely say that care for stroke could empower stroke survivors and their families to be cognizant of their disability and the ways to manage it, as well as on how to make appropriate decisions during their road to recovery. Continuum of care is very important. So this particular intervention can provide lots of drivers, lots of information for somebody with stroke and their caregivers to decide on what needs to be done, especially after going home and trying to look at recovery after going home. Concept of care for stroke can also be translated for many other disabling conditions, many other cultures, and many other ages. And public health practitioners, not just talking about people who are involved in the Department of Public Health, but anybody who's involved in providing support and care, treatment for people who have survived a stroke and their caregivers can optimize interventions like this to efficiently bridge the gaps in accessibility to rehabilitation services and enhance the continuum of care for people with disabilities worldwide, not just in India or in your country. So this could be kind of a strategy to look at for global for addressing the global burden of stroke care and stroke rehabilitation needs. So currently in Malaysia, what we do is look at a similar intervention, but the focus is on the caregivers. So we are trying to look at developing and evaluating a scalable solution for caregivers of stroke survivors in Malaysian context. And we are trying to look at the same procedure that was used for developing the care for stroke intervention. So we are looking at systematic development, and we have started to do systematic reviews on it. We have started to look at the needs of the people in the community, which is what Dr. Iqbal just presented before me. We are looking at continuum of care. So we are not just looking at there is an intervention if you won't use it, but we are looking at the patients and the providers as well as the policymakers connecting themselves to each other, providing good quality care for those who are affected by stroke and their caregivers as well in the country. We are looking at cultural appropriateness. So we are looking at a Malay version, we are looking at Indian version, we are also looking at Chinese version of the caregiver version or the caregiver intervention that we are planning to develop in Malaysian context. And we are also not excluding the needs of people who are affected by stroke and the needs of the caregivers. So we are considering that within the best content for the intervention. And we are looking at this intervention to have more focus on the caregivers in addition to stroke survivors, because they are very important. So it's we know that people with stroke are already struggling, and whatever is available primarily in a context like Malaysia or India or in low and middle income country context is the family. So if they are supported, the stroke survivors will automatically be supported strongly. So hence the intervention that we are trying to develop in Malaysia is strongly caregiver centered and driven by them. These are some of the readings. So all those papers that I had initially shared in the screen as photos, you can access all the details of this intervention and the important message that we want to give to the global supporting stroke survivors worldwide is this. And all these papers are published and are open access, so you can freely access and then read more details from the publications as well. Last but not least, I would like to kind of acknowledge and share my profound gratitude to the supporters, the collaborators, as well as the funders. And it's been a brilliant teamwork so far, and expect to complete the development of this intervention and enable a scalable solution for stroke survivors and caregivers in a Malaysian setting very soon. Thank you all for participation and listening. I'm happy to take questions. If there's any burning questions now, I'm happy to take it now, or I can be contacted in these email IDs and can answer your question through email as well. Thank you very much again. Over to you, Professor Jafri.
Anyone wants to ask questions, because the next speaker was supposed to start at 3:10, so we still have some time. Initially we wanted to bring everything down to 4:30. I'm not sure whether Dr. Suresh will stay on until the end, or are you going to leave us shortly?
I will try and be there in non-video mode, and if there's any
Okay,
questions.
so maybe anyone who wants to have questions given to Dr. Suresh, because we still have about 15, at least 20 minutes for us, because the next speaker is due to start at 3:10 p.m. Malaysian time. So it's now only 2:50. Any questions that you want to ask? You can also put it in the chat. I hope Puan Siti can also look at the chat in case I miss, because I'm sitting far away from the screen, so I might not be able to open the chat. But you may. Is there any messages from in the chat box for Dr. Suresh?
I have a question.
Hi,
Yes,
Iliatha.
go ahead.
Yes.
Yeah. Okay. In terms of what you were saying about providing participants with the internet in order to use the technology, how would, if you're going to scale it up, for example, how would that work, and how would you justify being able to provide this technology to people that currently have issues with accessing the internet and Wi-Fi? I'm just wondering.
Yeah. There are two ways to do it, Iliatha. Thank you for the question, actually. This is very important. So, in addition to the systematic reviews that I was explaining, I also did a review on, not non-systematic review on the internet penetration in India. So, kind of look at what were the barriers to using M-Health innovations, not just for disability, but also for general healthcare access in context, as well as low and middle income country context. What? Hello?
Yeah, go ahead, Suresh.
Yeah, sorry. So in terms of what was there in India, we were very happy to say that the penetration was, so the penetration was fantastic. We had lots of people in India using internet, and this gave us a kind of rough assumption that people, lots of people in India, including in the villages, use smartphones, and they have internet access despite the poverty that we're talking about, despite the access issues that we're talking about for health, and so that is one way of looking at it. We can say that lots of people are using smartphone technology on their own, and asking them to use that for stroke care, if that's the need, it shouldn't be a problem, and there is more acceptability, and that is what we found out in context. And in context where the internet penetration is not great, and people do not use a smartphone as much as people in other countries, say even for example in India they use it, but say for example in Malaysia we do not have more smartphones, just for example, which is not the case anyway. We try, the other thing that we did was to talk to the government and then provide them with the smartphone, including the internet access. So most of the countries are now talking about access to internet at home itself, free of cost, and so we are advocating the government and the systems to look at providing that as well. So yeah, we do have governments sharing messages, or say for example diabetic screening has become really a prominent condition, where anybody with diabetes now gets a text to say when they should go for a recheckup, when they should actually access the hospitals and things like that. So there's things that are happening from the government side, and then government is trying to create access for healthcare. And so the second strategy is to advocate to the government and ask them to help the patients with stroke and their caregivers to provide access to stroke rehabilitation and social support care as well, through provision of either a smartphone or just the internet technology. It answers your question, Iliatha.
Yes, it does. Thank you.
Dr. Suresh,
Yes,
after your home-based web-enabled intervention stopped, how do you make it sustainable in India? I mean, you started initially to give free internet, free that, free this, and then after you, at the end of your intervention and your study, today in India, what's happening to your home-based web-enabled intervention? Is it still alive?
Yes, it is alive, and the clinical trial is still happening, Professor Jafri. So we've just finished recruiting about 275 participants, and we are yet to see whether it is making a clinically effective difference in the lives of stroke survivors or not. And so apart from these 275 patients, their caregivers in the trial, we also have lots of others who are trying to use it. However, we have not launched this product, or we have not launched this intervention, and then we are not looking at scalability at this point of time, especially because we want to establish effectiveness of this intervention, both clinically as well as cost-wise. And then once we establish effectiveness, then I think it would be a great product for scaling up. If it is not an effective intervention, then I think the first step would be to look at revising or improvising the intervention based on what we found as the variable that reduces its impact and what its why effectiveness is low. If we can address that problem before we start looking at scaling up, that would be wonderful. So after we do that as well, so once we rectify or improvise the intervention for the exact variable that had kind of acted as a barrier for effectiveness, and sorted that issue, I would also go for another small study to look at whether the revised intervention is working as appropriate. Then, if it is effective, I will move ahead with scaling up. That's how I look at it.
Thank you. We have another 14 minutes so before the next speaker comes in. Any other questions that you want to ask? Remember, we have another discussion at 4:30 that will involve all the panels and especially interaction with the participants. There are 57 of us online. Any questions you want to give? Any burning questions, Dr. Suresh? If there are no burning questions, I just want to ask Dr. Daryani, are you able to start earlier? Are you there
Yes,
already?
Prof. Yes,
Yeah,
yes,
okay.
I'm there. I'm here already.
Maybe we can start earlier, and then we after Iliatha's talk, then we can all discuss in more detail again. Okay, Dr. Daryani, thank you for coming and joining us today on your very busy day. And your topic is stroke rehabilitation, caring for the caregivers. So the floor is yours. Please go ahead. You want to share your slide?
Okay. Thank you, Chairperson, Prof. Dato Dr. Jafri Malin. So just give me some few minutes to share my slides with you guys. Assalamualaikum and very good afternoon to everyone, to the speakers and also to the participants. Firstly, I'm Dr. Darus. I'm a rehab physician from the Hospital Raja Perempuan Zainab II, Kota Baru, Kelantan. And I would like to thanks the organizer for this invitation to share with everyone about the stroke rehabilitation, caring for the caregivers. So firstly, for the introduction, we just go through to one case scenario that happened to one of my stroke patients that attending our stroke rehab clinics. Basically, Mr. A is a 42 years old Malay gentleman with stroke in 2019 with right hemiparesis, which is limb weakness with cognitive impairment, in which he had global aphasia. He had inconsistency in following command because of his global aphasia with mood labile and also post-stroke depression. Mr. A basically is an engineer, married. Yes.
Are you sharing a slide or not?
Yeah, I'm sharing my slide. Can you see it?
Your slide now is black in color. That's your name there, and that's your slide that you're sharing.
No. I'm moving to another slide.
Yeah, because the slide has not moved forward.
Okay, just give me a few minutes. Then we start back.
Yeah, you start back. Thank you.
Can you see my slide now?
No, we can. Kita hanya nampak your slide on your view, not the presentation view. All right. Okay, it's coming now. All right. Okay, now it's okay. All right.
Okay. So I'm sharing with all of you is one case scenario that happened to our stroke patients attending our stroke rehab clinic. Mr. A is a 42 years old Malay gentleman, had a stroke in 2019, left him with right hemiparesis or limb weakness and with cognitive impairment, in which he had global aphasia. Hence that he is inconsistency in following command with mood labile and also had post-stroke depression. Mr. A was an engineer married with 4 children, and he currently lives in father-in-law's house after the stroke. The main caregiver is actually the wife only, and Mr. A is not able to return to work after stroke. He was admitted in our rehab ward for the first time after he had stroke in 2019 for 2 weeks for cognitive assessment and active rehabilitation. So after he's been discharged from our ward, his achievement is he was able to ambulate with quadrupod. And in terms of his daily activities, he was independent with setup, such as in feeding, or need some supervision or minimal to moderate assist in terms of other daily activities, such as upper garment or lower garment dressing. So this patient was on our regular follow-up for quite some times, but after 1 year having this post-stroke, during their regular follow-up with the wife suddenly burst into tears, and then on further questioning, the wife claimed that he is having difficulty to understand Mr. A because of the global aphasia, which is actually speech and language impairment. The patient was frustrated and sometimes scolded the wife by increasing his voice and also with incomprehensible words. And this response is not being understood by the father-in-law. So the father-in-law normally will hit the patient, and afterwards will give the wife 2 options, whether to choose them as a parents or to choose her husband. So what can we offer to the caregivers, and how can we help the wife in terms of these issues? And towards or at the end of the day, who will care for the caregivers? Rosalind Carter, the former US First Lady and wife of President Jimmy Carter, and also the president of Rosalind Carter Institute of Caregiving, quoted previously that there are 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those later who need a caregivers. So the definition of the caregiver basically is someone who is responsible for the care of another person, or a person who provides help with the need of another person, whether that person is paid or unpaid. And normally for the unpaid is actually the family members. So who are the caregivers? In one of the study done in 2019, which is an online survey of informal caregivers, this is a study done in the schizophrenia or schizoaffective disorder. They found out that 60% of the caregivers is actually the parents, while the 15% is others such as relatives, friends, guardian, or their own child. 14% will be their siblings, and 11% will be the spouse or domestic partners. And one of the study done in the stroke family itself, it shows that 52% of the caregivers actually their own spouse, and the other 48% is non-spouse, which include the siblings, the parents, or the child, or the others, such as the privateness and what so on. And obviously, the caregivers, the genders will be, majority will be the woman, compared the men, which comprise 21% in this study done by Susan McLennan in 2014. So who needs a caregivers? Basically, it's a big range. Yeah, it's either from disabled people, whether they have stroke, whether they have traumatic brain injury, whether they have stroke, whether they have spinal cord infection, or is there, or or the cancer patients, the dementia patients, elderly parents, and not to forget the disabled child, which mostly is the cerebral palsy child. So why stroke? And why we are focusing on the caregivers of the stroke survivors? As mentioned by Dr. Suresh just now, stroke is actually one of the top 5 leading causes of death and one of the top 10 causes for the hospitalization in Malaysia. And stroke is in the top 5 diseases with the greatest burden of disease based on disability adjusted life years. And we all know that stroke is actually an acute onset and is a common neurological disorder characterized by long-term dependency on patients on family members. And I believe that all or majority hospitals all over the world and also in Malaysia, they provide inpatient care for stroke. However, few focus on the stroke rehabilitation during the recovery and the chronic phases of the disease. And we know that most hospitals, especially in Malaysia, have patient enrollments or bed occupancy rate that exceed their capacity. And stroke patients are generally discharged within a week of admission or even earlier if they are stable in terms of medical condition. So little attention is focused on supporting and educating the caregivers, the patient discharged from the hospitals. Normally, stroke patient will be discharged with impairments such as example, paralysis, cognitive impairments that commonly compromise their autonomy and make them independent on family members for long-term and support. And the sudden onset of stroke provides no time for preparation or adjustment for the family members, and it leaves no choice for them to become the caregivers. And as a result, family caregivers must face the new problems related to the disease and its symptoms. But however, the needs of many caregivers were actually unmet. In a study done by Smith et al. In 2004, informal carers' experience of caring for a stroke survivors, where they explored the care experience of primary caregivers 1 year of the stroke, they found that the caregivers frequently lacked the knowledge and skills required to provide home care after the patients were discharged. What is contributing the most to the caregiver's distress? First and the foremost is the caregiver characteristic. Even the caregivers sometimes have personal health problems such as they are diabetic, they're also hypertensive, they has like a knee problem or other musculoskeletal pain. And also the stroke itself give a lot of caregiving demands. They need to have frequent assistance with their activity of daily livings, they need frequent supervision in performing their activity of daily livings. And also the caregiver resources, in which normally there will low availability of social supports even from the relatives or the family or from the other family members. And also caregiver appraisal, where they perceive the financial burden and lack of reward in terms of caring for the stroke survivors. So what can or how can rehab help these caregivers in terms of caring for the stroke survivors? There will be many factors that potentially influence stroke caregivers' abilities to manage caregiving demands after the survivors discharge from the hospital or even from the rehabilitation. But we only focus on 2 factors in this presentation. The first one is the severity of the stroke. The second one is the impairments of the stroke survivors. Severity of the stroke, I will divide it into severe or moderate and mild stroke. And whereas for the impairments of the stroke survivors, they will have residual limb paralysis or weakness, which make them difficulty in ambulation, or they can have cognitive impairment, which is speech and language deficit, as in the case scenario that I presented just now. And sometimes they have behavior and mood issue, the same as in the case scenario that I presented just now. And sometimes they will have sensory loss with it can lead to incoordination and also the balance issue. The severity of stroke, for the mild one, basically they doesn't really need to have any caregivers because they are quite independent in their daily activities. They are able to ambulate with or without aids, and majority of them will be able to return to drive or return to work. For those who considered to have moderate stroke, they need caregiver in terms of supervise or in to supervise to minimal or moderate assist, because in terms of daily living, they might be independent or they just need supervision or minimal assist from the caregivers. For the ambulation, they will be able to walk with walking aid or some assistance from the caregivers, and they might be able to return to drive or return to work after the stroke. But for those who have severe strokes, obviously that there are total care dependent, because normally there are bed bounds. They need caregivers in all activities of daily livings, and they will not be able to return to drive or return to work. So how can we help the caregivers? Normally, we will do the carer training or how to nurse the stroke survivors and educate the caregivers in terms of nursing the stroke survivors. For the carer training, normally we require them to be admitted to our rehab ward, which maximum will be 1 week of duration, and even it can be a bit earlier if they are quite okay or quite well trained after 3 or 4 days. And we train the caregivers how to handle and cope with the impairments basically. So the aim of the carer training is actually to reduce caregivers' burden, to prevent stroke complications such as contractures, to promote positive outcome for the stroke survivors, and the last one, to educate caregivers, and hopefully it can improve the quality of life of the caregiver. So what we do in carer training, first one, normally we will teach them how to do the frequent turning, at least 2 hours turning or positioning. We make them understand why they need to do the proper turning or positioning, because it can prevent pressure injury, which can have if to the stroke survivors if they don't do the proper turning positioning. And we teach them how to do proper transfer technique. The aim is actually for 1 person minimum to moderate assist. Normally, if the patient is bedbound, they will require at least 2 person, but we will try to reduce it to 1 person moderate assist. And the reason why they need to learn how to do proper transfer technique is to prevent injury to both caregivers and stroke, because they can have fall while transferring the patient from the bed to the chest or chest to the bed. And also we want to prevent mechanical back pain or muscle joint because of the frequent transfer that they need to do for the stroke patient. We also teach them how to do the strengthening and also mobility exercise or stretching exercise, which they need to perform at least 3 times per day. Normally, we ask them to do 15 repetition for each session, and we make sure they know what is the importance of the exercise. It's actually to prevent contractures or joint stiffness, to prevent any spasticity or muscle spasm, and also it can promote motor recovery if you're doing it frequently, as that we recommend 3 times per day. So they should know that once patient develop contractures or joint stiffness, there will be limitation in joint range of motion. So the patient have high risk to get pressure injury. They will experience pain. They will issue with hygiene. You just imagine that if you can't move the shoulder so much, so it's going to be difficult to clean the armpit and etc. And also it makes them to to have difficulty to mobilize the patient once the contracture set in. For the spasticity or muscle spasm, normally the patient will experience pains. So what can rehab offer to them? Now, we offer them botulinum toxin injection, which is lasted 3 months and need to be it need to be repeated. But the most important is actually the stretching or mobility exercise that we teach them how to do it at home. If there is presence of pressure injury, we teach the caregivers how to do the proper dressing technique. As Prof. Jafri mentioned earlier, some patients or some caregivers need to bring the patients to the nearest clinic for just dressing, and it requires cost for them, 15, 20 ringgits for the Malaysian, and for those who is from the low income, it's a big money, and it's really increase the burden for them just for the dressing at the local clinic. So by teaching the carer or caregivers, it will reduce the cost in terms of caring just to do the dressing in their own home. We also teach them how to do proper bowel management, because stroke patients normally tends to get constipation. So we educate carer for proper nutrition, make sure that the intake of fibers is adequate, and also we'll ask them to have good hydration for the stroke patients. And also we teach how to regulate bowel motion, and sometimes they need some medication that we can prescribe to the caregivers. We also help them in terms of bladder management. We make sure that they know that if the patient is on diapers or indwelling catheter or continuous bladder drainage, which is CBD, the most important is actually hygiene. And if the patient is on CBD, they need to empty the urine bag regularly, because it can prevent the urinary tract infection, or it can also prevent the pressure injury that the patient might have because of the wet diapers. So for the feeding part, especially those on rice tube feeding, we teach the carers the proper hygiene of the rice tube itself, and then the proper positioning during feeding. Because normally once patients on rice tube feeding, the carer just feed them on supine position, which is very wrong, because patient is actually needs to be upright position at least 45 degrees to prevent aspiration pneumonia or lung infection. We also make sure that they knows how to do the nutritional and also proper diet, and normally we refer them to the dietitian while the patient while the patient is in ward for the nursing care or for the carer training. And for some patient who can follow some command, we teach the carer how to do the oromotor and swallowing exercise in terms of to promote swallowing for the patient, and hopefully the rice tube can be off later. For those who have speech and language issues, normally there are three common problems that they face. Is either the first one is global aphasia, in which they are not able to communicate or not able to talk, and at the same time they are not able to understand what you are talking. Or number two, whether the patient is having expressive or broadcast aphasia, which are the non-fluent aphasic. Or the third one, whether the patient have receptive aphasia or Wernicke's aphasia, where they can where they can communicate with you, but they will have issues with comprehension. They cannot understand you so much. So normally we'll ask them, or we ask the carer to use some sort of communication board, flashcards, what we call is augmentative and alternative communication. And we also referred the patient to speech language pathologist during ward admission for the carer training. In terms of to help the carer burden, in terms of to help the carer and to reduce the carer burden, we also do proper equipment prescription for the patients, whether the patient needs hospital bed or a mattress, and we need to decide the proper wheelchair for the patient, whether they need standard detachment armrest or footrest wheelchair or lightweight wheelchair, or they need the reclining wheelchair. And even we do the assessment such as toilet assessment at home to make sure whether the patients need any commode wheelchair, and some of them might need the hoist just to transfer the patient. So we will try to facilitate all this equipment prescription for the stroke and also for the caregivers. And for the orthosis, normally we will prescribe a resting spring for the upper limb and lower limb, just to make sure the complication of joint contractures can be reduced by using the resting spring. So as I mentioned just now, the carer training and the equipment prescription, the aim is actually to reduce the caregiver burden, prevent stroke complication, promote positive outcome for stroke survivors, and to educate caregivers and improve quality of life for the caregivers. In one of the study done by Hayashi in Southern Vietnam 2011, Hayashi found out there are top 5 needs or concerns of caregivers in terms of stroke rehabilitation. First one is the stroke prevention. Second, information on the drugs that the stroke patients need to take. Recovery time after the stroke, and availability of the hometown hospitals. And the last one is ability of the stroke survivors to conduct activities of daily living. So what we did to the case scenarios that I presented just now, what did we have offered to the caregivers and how did we help the wife? So we admit the wife and we admit the stroke and also the wife to the rehab ward, mainly for the respite care, just to isolate the patients and the wife from the father-in-laws basically. But at the same time, we also aim for the others, such as to improve the gait pattern. We try to do the cognitive training for the patient, and we refer the wife to the counselor while they are in our wards. And we start medication to improve the patient's mood, because as I mentioned just now, patient's mood is quite labile, and he's quite frustrated because no one's understand him so much while he wants something because of the global FAZ. And actually we tried to arrange the family conference with their in-laws, but their in-laws refused to come to our ward and to discuss further about the patient's condition and etc. And currently the wife still under counselor follow-up, but now she knows how to learn the coping skill. Examples such as remove her husband from the family members if the conflict occurs. And with the medication, the patient is more calm now. I like to share this Nazalino Uluyam di Liverpool. I am not really sure whether any one of you followed Nazalino previously. Nazalino is actually a Malaysian who resides in Liverpool and wrote books, Uluyam di Liverpool, and passed away in 2018, if I'm not mistaken. But he had a stroke in 2017, and you can browse his wife Puan Ainun, or you can go to Nazalino Uluyam di Liverpool to show the struggle of his wife living in the UK without any relatives, and when the husband have a stroke, and the struggle that the family has with when the late Nazalino had the strokes. So I will always share this Nazalino Uluyam di Liverpool with my patients, just to make sure that they know how struggle is actually the caregivers. As you can see, what Puan Ain was written there, dengan 5 anak dan tak ada keluarga. So that means they are quite struggle without, there is no family members in UK. They just hoping for the friends to help them. And in the videos that they post in this Facebook, they show how they try to improve Nazali, the late Nazali, when he has a global aphasia, and improve to expressive, and later on was able to understand and was able to vocalize and with understandable communication. So for those caregivers out there, and also the and for the stroke survivors, you know, you will never walk alone. And hopefully with what this grant and Prof Kamara Imran will do, hopefully there will be a betterment in stroke caregiving. And with that, a big thank you, everyone. Thank you.
Thank you, Dr. Daryani. Very nice talk, very down to earth, very practical, also talking from experience. So it's now 3:27. In fact, the next speaker is supposed to go on at 3:50, but do we want Kim to have the get Dr. Iliatha to talk first, or we want to open the question and answers now?
I'll let Dato to decide on that. You're the MC, so just follow what be your plan.
Oh, I'm now the junta. Okay, so we have a few more minutes. So are there any questions that you want to ask Dr. Daryani, because she's based in Kota Baru, so in the heartland of the Malay land called the state of Kelantan. It is slightly different from Kuala Lumpur and maybe Sabah and Sarawak, because their cultural values and also there is poverty. So I just want to ask Dr. Daryani, I think she's been working with stroke caregivers for some time. So I remember when we were discussing how to make the apps, there was a question that we wanted to make apps. In the apps, we want to have a kind of a questionnaire to pick up depression amongst the caregivers. So, you know, that means from the handphone, there is a Q&A or software or a point score or whatever that you can ask questions to the caregiver to detect whether the caregiver has depression. And at the same time, maybe the caregiver can be contacted by a counselor, or the caregiver can contact the counselor, him or herself, to assess rehabilitation for the depression of the caregiver. So what are your comments on that?
I think it's a good innovation once you include the counselor inside the Q&A that's supposed to happen, because normally in stroke rehab, what we do the stroke depression. I mean, we normally ask this the depression among the stroke survivors. Basically, it's not frequently that we don't really ask the caregivers whether do you have depressed, why you caring for the stroke survivors, because we normally focus on the stroke survivors rather than caregivers. But as I said, as in the case scenario that I presented just now, it just so sudden, the wife suddenly cry in front of us, and not many that we have that kind of issues. But as I said, normally the respite care is actually for those stroke survivors. Is actually if we found the depression is more in the stroke rather than the caregivers. Most probably the caregivers doesn't open up so much, but hopefully once you have the Q&A with the counselor, it will like give better view for the caregivers itself.
Okay. The caregivers are not are not directly the patients. The patients are the stroke patients. But then we have this Privacy Data Act in Malaysia. So in the Privacy Data Act, whatever conversation, whatever treatment, whatever may be advised for the caregiver to be used to take care of the patient may or may not clash with our Privacy Data Act lah. Because the Privacy Data Act too is not only for sick people, it's also for healthy people.
Yes.
So
Yeah.
how do you see yourself if we had an apps, Kim managed to make this app, and we invite you also to be part of that team. So how do you think we can solve this problem about this Privacy Data Act of Malaysia and trying to talk and advise the patients? We also have medical legal because caregivers can sue us back,
Yes.
caregivers can take action against us. So how do you think in the just world, in the apps world, because the team is apps technology, that we can use this in the state of Kelantan especially?
I think, Prof, as what we experience with our patient that I give in our scenario, we ask the consent actually, the consent of the caregivers. We ask whether you want to see the counselor. I mean, the most important is the consent of the caregivers. Because normally, if the patient is being admitted in hospitals, we refer the patient to the counselor. We don't refer the caregivers. But this one, a bit of tricky, where we send a normal patient. It's not a patient. It's not a patient. We're sending someone which is normal. It's not our patient basically. It's just a caregiver of our patients. So we did ask the counselor, can we send this caregiver to you? And at the same time, we ask the caregiver also her consent, whether you want to see whether you want to see the counselor or not. So I think the most important is actually you need to have the consent from the caregivers. If the caregivers give their consent to be to be referred to counselor, I think it shouldn't have any problem.
Yeah. Another thing, Dr. Daryani, after listening to your talk, I make all the notes about your talk. We will need to prepare at least 20 videos for the caregivers, to take care of their patients. So 20 short videos. And, listening also to Dr. Suresh, how to wear a sari, of course,
Yes.
in Kota Baru, we don't wear saris, but we wear something else. How to wear the tudung, how to wear your shirt, your sarong and all that. So there are 20 videos that, if I listen to you, there's a lot of information for the caregivers,
Yes.
Do you think that number of videos is too much?
If you ask me, if the video is quite simple and the caregivers can follow, it shouldn't be any problem because it can help them a lot. Even not necessary that the caregivers have that 20 problems in the stroke survivors. As I said, one of the video is like how to dress the pressure ulcer. So most probably, if the patients have no pressure ulcer, so they can just ignore that video. So the most important is actually, I think, only few, such as transfer technique, turning positioning, and also the stretching and strengthening exercise, in which, if you can see Dr. Suresh just presented, they also have some exercise form and what's so on in their videos too. So I think we don't need to do one video for the caregivers, one video for the stroke survivors. We can combine like stretching and strengthening exercise in just one video, so the carer and also the stroke survivors knows how to do it. So
Yeah.
it shouldn't be that too many videos, because it can be combined for both of them.
Yeah. I have a question here from Tracy Chan. She's asking whether group support for the caregivers, that means to say, between the different caregivers in your hospital, do they have a support group?
In our hospital, they don't have the support group. I'm sorry, but for the other like spinal cord injury, yes, they have a good support group. It's quite difficult because first, like if you are in Kuala Lumpur, they will have NASAM, but I've tried to find there in our community, especially in HRPZ, we don't have that kind of support group. But I have few what we call is stroke survivors who are able to do well after their strokes, and we call these stroke survivors to come during to come to the ward and give some motivation talks to them. And I think if I'm not mistaken, there are a few organization NGOs in Kelantan that support for the stroke. If I'm not mistaken, it's like Persona, and also I think it's Persona, is if I'm not mistaken, but I don't involved in that NGO so much, so I'm not able to tell you so much about that NGOs.
Okay, good. I think I want to leave the rest of the question. So, okay, with Tracy Chan asked about support group via handphone. Can support be done via handphone? I suppose it can.
I
No?
suppose it can. Yes, but we need to find the proper stroke survivors and also the caregivers that can help us in terms of doing the communication via the phone.
Yeah. Okay. So I think Kim, maybe I'll get Dr. Iliatha to talk early, or if she can talk early, and then that, because right now it's 3:40, and there's still 10 more minutes. So maybe we can keep all the discussions after Dr.
Right.
Iliatha's presentation.
Yeah, I think that's a good idea. And in fact, I think I see Dr. Wan Ashraf. I think Dr. Wan Ashraf is Vice President for National Stroke Council. I think so. Is that you, Dr. Wan Ashraf? I can make you a panelist, so then we can have a very good discussion at the end of the session. So yeah, I think that's a good suggestion. We let Dr. Iliatha to
Yeah, okay.
finish the
So,
session. All right, thank you.
Dr. Iliatha, if you're ready, your topic is virtual skills, or is it development of a virtual skill training and resource center on behavior management in chronic illness for lay people in low and middle income countries, LMIC. That's what Malaysia is, I think, LMIC. So, Dr. Iliatha, the floor is yours. Please go ahead.
Thank you. Can you hear me okay?
Yeah, you're loud and clear.
Okay, great. So just apologies, it's flu season in the UK, so I've just recovered from the flu. So apologies if I'm coughing and spluttering. But I'm really pleased I could make today, and thank you everyone for organising and really interesting talk so far. This one I feel nicely follows on from the previous presentations. This was a funded, I'm going to discuss a project which was developed. It was a funded MRC project, a small project, for a phase 1 study, and we based it in Bangalore in India. We worked with a team there from Public Health Foundation of India, and the idea was to develop a training center and a resource center that's online, accessible online, and also provide online live training as well. And the idea was that it would be behavioral, not just behavioral management, but psychological management for people with long-term conditions that's relatable to any country. So what we did, we decided to focus primarily on one condition, which was diabetes, as at the time we were working with the team in India on diabetes, and and the training itself would be on helping not just patients, but also the carers. So helping the carers and the patients to manage this condition. In this context, it was diabetes. Helping them with their behavioral management, but also psychologically as well. So helping them psychologically, whether it would be kind of stress management, depression. And we called this program Patient and Carer Conversation, PCC. So the goal was to provide carers, patients with psychological techniques that will help to improve the conversation between carer and the patient with a long-term condition, and help set goals for better self-management. And we wanted to extend not just family caregivers, but also healthcare volunteers, and for this context of the presentation, to see whether it's also useful and transferable to healthcare professionals as well. Perhaps this is something as yourselves as healthcare professionals you're perhaps already doing or being trained in. So maybe in terms of the discussion, these might be kind of conversational topics that might arise as well. And we had our virtual platform, which was a website with consisting of 9 lecturettes. So they were split into 2 90-minute training sessions, and also they were available online as modules, so you could access them as modules. Within the training sessions, there was also activities, exercise activities and quizzes, and they consisted of psychological and communication techniques. So the communication techniques we used were that of motivational interviewing and cognitive behavioural therapy, which I'll go into detail in a moment. And we also included a disease-specific lecturette. So in the case of this small study, it was diabetes, but it could also be transferable to other long-term conditions such as stroke. We also included a substance misuse lecturette, and the example we had for the study was risk of smoking. So the lecturettes were categorized as follows. So you had the condition focused, smoking, which was the substance misuse, and then the psychological techniques, kind of enhancing communication, which we categorize as the psychology behind chronic illness, building a partnership and goal setting, active listening, open questions, positive feedback and reflections, summaries, maintaining change and dealing with setbacks. So again, this is derived from motivational interviewing techniques, cognitive behavioral techniques. So what I will be doing now is basically presenting some of the material that we use to train the teams over in India. I presented this to family caregivers, healthcare volunteers, and also the family caregivers were categorized into new carers of the patients, and carers that have been looking after or been managing their spouse or their mother or father's condition for many years. And we also, while we were developing this program, we also had some focus groups, so it's kind of participatory workshops with patients as well. So they were able to review the materials and provide feedback. And generally speaking, we had positive feedback that this was something that's needed, and it was very encouraging that we had many people attending the training sessions. And what happened after the training sessions, and what we would like to do is to develop it further, refine it. And what we found when we did provide the training, that what was actually key was this interaction between the person providing the training and the people listening in. So there is some work to do in terms of activities, useful activities, to encourage that dialogue between the carer and the person providing the training. So I will run through the lecturettes. So the lecturettes are very much outlining what we mean by the headings. So for example, the psychology behind chronic illness. So I'll run through each lecturette. And if there are any questions, I won't be able to see the chat from here, but we can always leave questions to the end as well. So understanding how a patient may feel if they have a chronic illness and how they can manage their condition. So this is why we want to understand the chronic, the psychology behind chronic illness and behavioural changes. So how would one feel if they were diagnosed with a chronic illness? Initially, they might feel shock, denial, some form of loss and grief, anxiety and depression. So an anxiety and depression is quite a reasonably high percentage of people that can feel this with a long-term condition, and the reactions may last long. They can have a negative effect on the illness because because of their mood. They mismanage. They're unable to manage their condition as what's demonstrated as part of their care package. And what they should be adjusting to is the symptoms of the disease, the stress of the management, the vulnerability that they're feeling, gaining control, increasing their self-esteem. They may have financial concerns and changes in family structure. So quite a lot of areas that they will be feeling initially that need to be addressed. This. So by providing psychological support, you are helping them to manage their condition and lifestyle change. And in terms of diabetes, it's very much the classic behavioural intervention components, such as better diet, physical activity, stopping smoking. For stroke, this would be other areas as well. That was described earlier with the previous presentation. So very much physical aspects, and then there's cognitive vulnerabilities as well that may need to be addressed. So this is important because adherence to treatment is key in providing the patient with a reasonable and often normal lifestyle and lifespan. Due to psychological effects, the patient decides not to stick to the treatment schedule. It can lead to physiological complications. Again, example of someone with diabetes, it can increase high blood pressure, numb feet, blurred visions, and that's just kind of not the severe end of the scale in terms of complications. There are psychological effects of being diagnosed with diabetes that cannot be ignored, such as failure to emotionally accept the diagnosis. So again, coming back to the importance of acceptance psychologically of the long-term condition. Therefore, the best option for attaining good self-management practice is to also have good psychological acceptance. And part of this is building good communication with the patient and those around them, those who are close around them in terms of family carer, or if it's on a professional level, if it's their key healthcare clinician, or in the case where we had in Bangalore, where they have the healthcare volunteers that would be accessible to them. This would be key for them to build that partnership, and again and set goals. So the idea would be to set goals to improve the psychological and behavioural management, to build a basic understanding of what the patient needs, how to change behaviour for better self-management. So a step-by-step process for patient care conversation is key. It is important that both yourself and the patient have enough knowledge about the process so that you can understand when different techniques should be used and why. Discussing these steps with the patient is advised in order that they understand the principles and processes underlying patient-carer conversation. This is key to forming a partnership with your patient. So we're setting the scene in terms of this is not just for the carer, but also this is something that they need to work with the patient. So setting an agenda, building a partnership between patient and carer is achieved through setting an agenda that is led by the patient. This is because the patient is the expert on their health and well-being. Only then can both parties work in collaboration to develop a shared understanding. The patient must accept that they need to make their own decision and take responsibility for that decision. As a carer, and I've put the other examples, but we're using carer as the key example, or a health assistant, health professional, you need to empathise to more fully understand the patient's situation and why specific decisions need to be made. So compassion is key, seeking to act in an interest of the patient and allow understanding to be developed without being negative towards the patient's experience or behaviour. Being positive and encouraging towards changing behaviour is one of the main roles of the carer. And also supporting positive beliefs, which may not necessarily be easy at the beginning. Here the carer supports the patient to believe in their own ability, self-efficacy, increasing their confidence. This allows the patient to move away from being indecisive about making change, to talking about making changes and taking positive steps in their lives. So we really encourage to set one goal. So again, in terms of the diabetes patient, so that one goal may be to start reducing their sugar intake, i.e. Carbohydrates. So that would be their one goal, and how they would go about doing that. So they would go through these stages to set a goal, and that would be the key communication between them and their carer. So deciding when this goal will be set, discussing what they will do to prepare to set the goal, So what other support is available? Social support from family or other services. Discuss how they will prepare for any setbacks. Don't get down, just keep going. So you can do it. In terms of positive motivation, because that's another key issue with patients, particularly when they're first diagnosed, is motivation and keeping going. So being that cheerleader almost for the person that they're caring for. So set a time for a follow-up meeting. So as a family carer, it wouldn't be so formal in terms of having follow-up meetings, but I think it would be important to have that conversation and set a goal for that time to have that conversation to discuss the preparation and progress of the goal. So that's improving, excuse me, improving and building rapport and partnership and setting a goal. So around that lecturette would also be dialogue activities to show examples of how you would initiate these conversations, manage these conversations, have positive quotes in order to support the patient. So lecture 5 is on active listening. So this is another key skill within counselling in particular, and this is where, as I've mentioned, we've used techniques from motivational interviewing. So patient-carer conversation relies upon the patient and carer working together in partnership in order to achieve a set goal. Without a shared understanding, this cannot be achieved. By engaging in active listening, the carer can help the patient to consider specific areas that prevent them from changing. We need to consider the reasons preventing change from different perspectives. This highlights the purpose and benefits of applying active listening. It is important to know how to use these skills with the patient. So here we have 5 top tips. Look at the person, excuse me, eye contact, look at the person and stop the other things that you are doing. So I think in terms of, as a professional, probably easier because you have this allocated time with the patient. As a family carer, that's probably something that's most likely would need to be acknowledged and addressed in terms of the training. This is time to support the patient, and this is time for active listening. Be sincere. Number 2, be sincere, sincerely interested in what the other person is talking about. Keep focused on how the patient's feelings and emotions. Ask open-ended questions, which I'll come to in a moment. Make reflections. Be empathetic. Always remain non-judgmental when discussing a patient's issue. Be aware of your own feelings and opinions, but try to avoid conveying them. So this is very kind of some simplistic overview of active listening, but actually quite key points, even though in reality, particularly as a family caregiver, for example, these are things that can't always be maintained, but we want to address them in the training for them to practice as much as they can. So again, part of the motivational interviewing techniques for active listening is open-ended questions, providing positive feedback, reflective listening, which I'll speak in a bit more detail in a moment, and summarizing. So these are the core components of active listening. So and then lecturette goes into open-ended questions. It explores how to use, this lecturette explores how to use open questions during a typical conversation with the patient. Open questions allows for expansion and elaboration. Closed questions allows for confirmation and clarification. So you will swap between the two in a natural manner. And for those of you who are doing research, and particularly within our team, when we talk about open-ended questions, we use it a lot within qualitative interviewing, as many of you will know, in order to get as much out of the person as possible. So open questioning is one of the most important tools in the psychologist's skill set, because it allows them to elaborate on a patient's responses. This then provides additional details about the situation for further inquiry. You cannot achieve this with closed questions. Open questions provides the patients with the power to control the direction of the conversation. And at this stage, we would provide examples of open questions and closed questions, and have some activities around this in order for the audience to practice. It takes the emphasis away from feeling of being interrogated or pumped for information about their condition. As you can imagine, many patients, many people with long-term conditions, or initially trying to understand their long-term condition, they may be quite defensive. So again, this kind of emphasizes the importance of how communication can really support the person with the long-term condition. So closed questions can shut down the patient prematurely, therefore it gives you less to work with, and the responsibility for change is back in your court. So this does, again, come back to kind of having good counselling skills. And as a counsellor, you're actually there to listen and support, rather than dictating the conversation. Open questions allow the patients to take some control with the direction of the answer. It also signals that you are interested in their perspective. So lecturette, positive feedback and reflections. So this is also a continuation of active listening. Positive feedback are statements which show emotional support and encouragement for an individual. This is important in counselling. Set the mood and tone of the consultation, making it feel positive, allowing patients to move forward and feel empowered. So again, this would work as a healthcare professional, healthcare volunteer, but as a family carer, you're not thinking of it as such as a consultation, but it's really kind of a day-to-day support, and helping their loved one feel positive, and empowering them to manage their condition. Positive aspects of the patient, their behaviour, their achievements and their efforts. It can create an atmosphere that supports change and the idea of change, making that patient feel uplifted and confident. So this is, we're talking about positive feedback and reflections. Reflections provide the patient with the opportunity to consider a different way of thinking about what they have said or what they are doing. It encourages existing resistance and provides evidence of motivation that can be discussed further. The process of reflection is part of the collaboration between the carer and patient. The role of the carer is to assist the person in developing these skills. And again, we would have some form of activities in order to help them address when the patient is speaking, how to provide positive feedback, how to provide reflections. I do feel from the initial workshops and training that we did, I don't feel that we've nailed the activities directly for them to feel that they're, even though they've said they feel that they've learnt new skills, in order to really apply it, we're not quite there yet. So part 4 of the active listening is summarising. So how can summaries help patient-carer conversation? So here are the 5 key points. So summaries are a break point in the conversation. This is useful in controlling and directing the conversation. Summaries can be used as a way of concluding one part of the conversation and moving on to a new topic. Summaries are a way of ensuring understanding. They break down information you have discussed with the patient and communicate it back to them. Summaries can be used as a way of regulating the speed of conversation if you feel it has gotten out of control. Summaries have patients organize their experience and reflect. And then lecturette 9, maintaining changes and dealing with setbacks. So this is also a key area, particularly when you're thinking of a long-term condition. This is not just a quick fix of setting a goal and that everything's fine, because it is a long-term condition. You have to think about what happens when people feel that they're failing with their goals, they're not fulfilling their original goals, and they go back to their old habits. And this is also a technique from motivational interviewing, which was initially used for addiction. So it's something that, with dealing with setbacks, it's something that can easily not be addressed when people provide interventions. Really, we're thinking about long term. So this is, I feel, a key additional area that needs to be unpacked further. So, for example, once the patient has set the goal and has managed to change the behaviour into a positive routine, they may go back to, i.e., eating unhealthily, not exercising or smoking again. Part of the role of the carer is to support the patient by ensuring they stay confident to keep moving towards their goals. This involves problem solving the setback. To solve problems, you must assess together with a new outlook and from a different point of view. The patient may be resistant to deal with their setback. However, using a problem-solving approach and recognizing that setbacks are often part of the progress can help the patient maintain their goal. Everyone has a different reaction when a problem arises. As a carer, you're in a position where you can help the patient to problem solve the setbacks they face. So setbacks really should also be discussed at the beginning of setting the goal in quite a bit of detail. So you're addressing potential resistance afterwards when the patient feels that they've been unable to continue maintaining that new goal. So this is the very brief overview of the training itself. I haven't discussed in detail about the study, but it was and it is kind of in the developing phase of the materials, needs refining. From the feedback that we did get positive feedback. They did feel that it was important. It was there is a gap here that this training can fill, and also they did feel that they're learning new skills, and that was across healthcare professionals, the volunteers, healthcare volunteers, and the carers. What we just from providing the actual training itself, we did feel that there wasn't enough interaction. It's quite passive. So activities will need to be brought in from the beginning and more in order to generate the discussion. So that's a technique in itself that we'll need to develop. Other areas of improvement, we've developed a website, the materials. Other areas would be to provide short videos particularly if the healthcare professionals and assistants are looking to get some form of certificate. So if they're going to participate in the training, they can have some form of certificate to show that they've completed this course. So ideally, it would be great to have the opportunity to do everything online, either if it's live or just through the website. So that's another area to look into. And we also developed a chatbot, which was very preliminary. We developed a chatbot it was used by family carers. So that was it's very preliminary stage, and it hasn't been developed further. So this is an overview of the patient carer conversation program, and hopefully it's something that can be used for and transferred for other long-term conditions and audiences as well. Thank you for listening.
Thank you, Dr. Iliatha. So right now we are at 4:12. So I think our program has ended. If you're talking about the talks by the specialists, can you?
Oh, you've muted.
Yeah, okay. So thank you, Dr. Iliatha. So Dr. Iliatha finished 18 minutes earlier. That's good. At least we have more time to discuss. So Dr. Kim wanted to unmute everyone. That was his plan, so that people could ask questions to all maybe we would first specifically ask is Dr. Suresh on board?
Yes, Prof. Jafri, I'm there.
Okay. Because I thought you said you just wanted to be on audio or something.
Yes, I have to in some time.
Yeah, okay. Oh, you managed to change into another sweater.
This for the school run, yes.
Yeah, okay. So now we have Iqbal, Suresh, Daryani, Iliatha on board. So I would like, there are about, I think minus, there are 52 participants, minus myself because I am on my handphone. So in fact, it's 51 participants and 15 working administrators, including the panelists. So I would like to open to question and answers. And I don't think any question is a funny question or a silly question because we are talking to people who have had a lot of experience. And even Iqbal has given very interesting data. Dr. Suresh has got experience from India. Dr. Daryani is a very senior specialist who has special input about the Kelantanis, the special group of people who have special needs, we say. And Dr. Iliatha, who has already had lots of experience even with non-communicable diseases. So any of the do you want to unmute them?
Unfortunately, I was trying to unmute everybody, but I think I can unmute the panelists, but I can't unmute the attendees. So what I'm going to do is, so I think if anyone wants to ask question, kalau nak tanya soalan, just raise your hand. or type your name in the chat, then I will unmute, because I can only unmute individually. I know that we have Dr. Wan Ashraf. I'm very, very hopeful that Dr. Wan Ashraf for Iliatha and Suresh Information is the Vice President for Malaysia Stroke Council. So I'm very happy that that he's here. So you know, if Dr. Ashraf can hear us, maybe he can type something, then I'll, make you a panel and put you in the panelist box. However, I think maybe so are we inside? Are we starting? Have we started the Q&A session, Dato? Or
Yeah, I think we can start the Q&A session.
Right.
And now the Q&A session is open to Dr. Iliatha, Dr. Suresh, Dr. Daryani, Dr. Iqbal. So I know everybody have given their presentation, and they're very interesting presentation. And I think they are important to help us also in our project here in Malaysia. And especially I've heard very interesting things from Dr. Daryani that some even I didn't think of, but now it's in my hippocampus. So I said, okay, there's so many videos you have to make or information for the patients. And then from Dr. Iliatha, even though she was talking about diabetes, now I see, okay, there are so many things. These patient-carer conversations, these are quite interesting. I do not know how we're going to put it into our project, Kim. And of course, we have Suresh. Suresh has a vast experience in an Asian community. The Asian community may not have the same cultural values like in Kota Baru, Kelantan, but at least we are Asian, and Asians are very unique people, I can tell you. So, so maybe there's something that also Suresh can advise us. So please ask questions. Maybe the students, the postgraduate students should ask questions, because this might help you in your methodology, that might help you in your discussion, in your academic work, your academic study. So can I open the floor to the questions? If you do not want to ask in English, you can ask in Malay, and then if we need to, we can translate. If it's possible, I think everybody speaks reasonable, good English for everyone to understand each other. Yeah.
Right. Dato, why not we let Dr. Wan Ashraf, he's the Vice President for Malaysia Stroke Council. I had he's inside the chat box, the panelist now. So yeah, there he is. It's really a busy man. Dr. Wan Ashraf, any comment from you? I mean, being one of the most important person in Malaysia when it comes for stroke. Silakan.
Assalamualaikum.
Waalaikumsalam. Yes, we can hear you clearly.
Hi everyone. So, thank you for the invitation. Sorry because of at the background. I'm at the background just now. I am not too sure about the discussion. What is the objective before? But I can see this about post-stroke caregiver, right? Yeah. So
Yes.
yeah, from Malaysia Stroke Council point of view, if you notice that we just launched the World Stroke Day recently, and the idea for this year is basically to make people aware of stroke. So if I can share over here, in 2016, when I first started to be involved with Malaysia Stroke Council, we are a bit scared because we are only talking about thrombolysis and thrombectomy. 2016, because of thrombolysis is being approved in 1995 and thrombectomy in 2015. But in fact, the one that you're discussing today, post-stroke care and stroke prevention, is 80% of the population of stroke will need this. So this is very relevant. And I saw in the chat, Tracy is mentioning about caregiver support. This is very relevant in this part of the world. The access to post-stroke care is actually very much limited. So I think you should continue, and we should have more study like this, and maybe multi-center throughout the whole Malaysia. I support that if possible. That's what
Thank you.
I think, and
Yeah.
I hope to see the whole picture from this post-stroke care. But stroke, there's a lot of things to study, but I think Prof. Kamarul, I was about to contact you again for the primary prevention and secondary prevention using the stroke riskometer. Let's set the date for that in the future.
Yeah. Don't worry. But I think one important aspect that we are looking at now is for the carers, the caregivers. You know, we might be focusing a lot on patients, right? So and so much so that we have forgotten that there are carers, caregivers that are also important for us to take care of. So that's basically what we are looking at. How to make sure. In fact, Tracy Chan asked question there, and caregiver burnout. Any screening tool for caregiver? I mean, are you looking after stroke? Family member who is having stroke, like a month, and then 6 months, and then a year. One point of time, you'll get very, very tired, and so I think maybe we can, if any of the panel would like to answer Tracy Chan's questions. Caregiver burnout, any screening tool? Over to you.
I have only a few minutes left for this meeting, so I'll basically thank for the opportunity, and I would also like to make my final comment for the audience. Firstly, to thank all the speakers for their wonderful insights that they brought in terms of what should be the kind of focus that we should have for caregivers, especially in a context like Malaysia. There were lots of key points or drivers that was there coming from the speech. One from Dr. Iqbal, we had the very clear-cut demand for rehabilitation services, and also the need that is there from the caregivers in terms of both educating them about how to provide caregiving services, also on the other side supporting themselves as a group, and also for being supported, that there's a need in a context like Malaysia. Dr. Daryani gave a very, very clear, precise picture of what is happening with caregivers and there are two key points that she provided. One was focus on interventions related to teaching the caregivers about how to take care of a stroke patient, and also teach them how to manage themselves amidst of the unexpected circumstances they are experiencing because of stroke that somebody is experiencing in their family. And Iliatha was very, very elaborate and comprehensive to say that the psychological component must not be missed out, and we should focus on those components as well. And finally, all the relevant questions that Prof. Jafri was asking, and also the recent comment from Dr. Wan Ashraf in terms of looking at the burden of stroke in Malaysia, and also looking at prioritizing stroke care and rehabilitation in this country, and then moving forward towards meeting the needs of people affected by stroke and their caregivers. And linking that to the last question that was asked, stroke screening tool, I would basically say that screening tool is a tool to assess whether they have burden or not. But my suggestion is to go to the caregivers and then talk to them either individually or as a group to understand what exactly are their needs. The screening tool can obviously provide you a positive or a negative indication of whether there is a burden or not. However, that is not what the caregiver wants in terms of support from you after understanding whether they have burden or not. They want some support, and to understand what kind of support is required, it's always good to have qualitative research or interviews with the real-time experience of what has been the caregiving experience and what it takes to provide care to a stroke survivor in the context, and that would give a better idea for looking at options and solutions for helping reduce the burden of the caregivers of stroke survivors. There's also another question related to app. So how long it took for me to develop the stroke care app, and how you developed it? Is it by hiring app creators? So this is something that's very, very important. And I did hire a stroke app developer. However, I oriented them with lots of training sessions and ensured them that they understand the health and the rehabilitation component of it. And that is when it was a success. And it took almost 6 months for me to develop the app alone. I will again like to thank you all for the opportunity. And I'll try and be online, or if there are any questions, I request you all to email me the question. I can always get back to you. Thank you all for the opportunity.
Thank you, Dr. Suresh. We have a question for Dr. Iliatha, which is sent by Dr. Nur Faiza. She wanted to ask about the method of delivering the training, whether it was using video calls or online courses.
Yeah.
Can Dr. Iliatha answer that question?
So initially we developed the website so the carers could access the modules online, and they could do the activities themselves. And then later, after some developmental work, because we had participatory workshops, even though they thought this was great information, they felt that they really needed someone to provide the training, to provide initially the training, and then it would be good for them to be able to access the online materials themselves. So in answer to your questions, initially we had the online course, and then we provided the training. We set up live sessions, but it wasn't face-to-face. It was obviously due to the pandemic. It wasn't face-to-face. It was through using Teams. But another good reason for using online training course, a live online training course, is that it's more accessible. So anyone could zoom in. For example, particularly with family carers, it was more flexible for them to access the training course online. So I think moving forward, we will probably look at providing live online training course, and then we'll be able to reach out to many more people and provide the training that way.
Dr. Iliatha, can you tell us in your work in India, you must have had some bad news as well. I mean, problems. You're presenting us all the good stuff, but what problems did you have when you did this in India? How did you overcome them, and what's the message to us in Malaysia, maybe so that we don't hit the monsoon or hard weather like you did maybe when you had problems in India?
Yeah, so I think there's a few issues. One is, do people really think this is great, or they're just saying, they're just saying that to please the interviewer or the trainer. I think that's something, and I wasn't able to go over there. So that's something that I need to spend a bit more time to assess individual opinions on the actual training. So that was the initial issue. After further kind of diving into feedback from carers, they did find some areas where for example, carers that have been looking or have loved ones with the condition for many years, they found it a bit too basic for them. So in terms of developing the training sessions, developing the materials, it does need a bit more work. For people that it was new to them, they found that it was insightful, although again, as I've mentioned, one of the key issues was the training package should be a two-way conversation streak between the trainer and the audience, and it was difficult to generate that conversation with them. So again, it's kind of back to the drawing board in terms of providing these activities that's going to generate more conversation. And then the third issue was the technology itself. And we developed a chatbot. So the idea would be that we would check in on the carer, how they're doing with their training course, if they're applying any of these techniques, has it been useful? And we would develop it with the company in the UK. But there's some teething problems, I think, again, either with the technology itself or the questions. They didn't feel that they were, they felt that they were repetitive. So again, there's quite a lot of work that needs to be done with the chatbot. But until we get the actual materials themselves up to scratch, I think the chatbot needs to be developed later on. Other areas, I think a lot of it comes down to the interactiveness and the website. Again, because we had such a short time to develop it, it's not as interactive as we'd like. I think that they were the key issues.
Okay. Thank you very much for sharing. I'm making notes. Yeah, so that maybe during our discussion in Malaysia, that at least we get some wise ideas or comments from you, so that we wouldn't fall into the same trap. So
yeah.
Thank you very much. Any questions from the rest of the participants? Questions? You may want to ask questions also to Dr. Daryani, Dr. Iqbal as well. And especially the students are, the postgraduate students are typical Malaysians. They don't want to talk because they're scared, or they're scared they will ask a wrong question. But, no question is right or wrong, Just ask the question. Maybe the wise, experienced speakers can give inputs, So anything you want to add in, postgraduate students? Because I know there's a whole lot of postgraduate students here, master and PhD students, who may want to ask questions about. Or maybe Kim knows some students who are shy, very, very shy. Malaysians are very shy people,
Yeah. They are courteous.
Courteous.
But you can raise your hand. If I see your hands raised, I'll unmute you, so you'll be able to talk. So we'll see. I'm doing two jobs here, talking and also making sure the technicalities is also taken care of. and we have also, yes.
Sorry, I have a few other points on tech development, just from this small study that we developed, but also with another Malaysia team that I'm working with. This is in gestational diabetes and it's preventing diabetes after pregnancy, and again, technology development issues that arise where companies choosing a good company with experience within developing health interventions. I think that was key, and that's something that we didn't do. And now we're going back to plan B, kind of developing something ourselves. But that, that was that's one key point. Another one is with tech development, it's very much iterative approach. So really having working internally with the team, but also with the user themselves. So having a number of workshops with the information, not just the information, but the technology. Is it usable? Is it workable? Imagery. Is it inviting? And is it easy to use? And we did use there are a couple of digital development frameworks, and again, Suresh has probably used this within his program as well. That needs to be applied, but it does feel that there are very common pitfalls within digital development. So we may need to look into that again once we get cracking with the actual digital development stage.
Yeah. My experience with digital development in Malaysia, the companies don't stay very long, and then now with the COVID, a lot of companies have closed, and I've experienced where companies take money and then they disappear, and nothing is there. So that's also very dangerous. And the gestational diabetes project was another Newton project, I think, with a Malaysian, if I'm not mistaken, a Malaysian scientist or Malaysian specialist working in UK, and our friends from Kuala Lumpur. I'm not sure whether it was UKM or or I remember because that was the first group of Newton grant applications, and I was in that group trying to get a grant that was unsuccessful, of course, and then I didn't know that the gestational diabetes group was going to use an apps, or they actually did tried to use an apps.
Yeah.
And,
so yeah.
So that's pretty tricky, I think. Maybe I don't know. So I think what we did is we wanted to look for someone that we can trust and who had a track record, because there's so many companies out there that they stay around for 1 year and then they close down, so they're just there for 12 months, and then the next year you're unable to sustain your apps, and then the apps is just something on your handphone that doesn't do anything. And I think we hope that doesn't happen to this project. So any questions to Iqbal? Iqbal, if you were, after doing your study, and after listening to Suresh, Dr. Daryani and Iliatha, do you think you would like to make any changes? Because they have presented their point of view, what they did, you did your study. Do you think that you would want to change things or do something better or whatever?
At the moment, Prof, I think because I still think I'm the one youngest among all of or the least experienced among all the presenters, and I'm looking on a lot of things. I think from the perspective of presenters presented before earlier, the new views that I can see, and hopefully and most of the presenters present here, I think with the experience that I had been through during the interviews, a lot of the issues I think we covered already, with the issues that been raised by the presenters and that I interviewed with respondents earlier before. issues on the education, all of these been raised up during the interviews that I have been with them. So I think looking forward in this is applications will help on their education, and as well all this problem can be solved by some of intervention. So I looking forward until the after this is about the pre and the post intervention will help in term of assessment later on. We can collaborate on this. Looking forward on the post intervention on the knowledge and everything after this.
Okay, Iqbal, from a very young man, right, young mind, who has listened to Iliatha, Suresh's lecture, Daryani's lecture, maybe there's something that you can improve. Maybe if not today, soon, because the theme of the talk is from a betterment in stroke caregiving during COVID-19. Okay, COVID-19 is slowly becoming from an pandemic to, I don't know, epidemic or whatever you want to call it, even in Malaysia. And the title is From Manual to Modern Apps Technology. So I just want to ask our doctor from HRPZ, Dr. Daryani, whether, do you think in the state of Kelantan, where most people have handphones, of course, but are they modern enough and current enough to be able to use a modern app technology to help to care for their parents, their siblings? And do you think, in your experience, I think you are also a local Kelantanese, if I'm not mistaken?
Hi.
You are, okay. So, there's this culture base as well. So do you think that this modern apps technology in Kelantan will be just a waste of time?
From my experience, Prof, if the patients, elderly, not many of them are quite well versed with apps, the phone apps, the mobile apps, unless if they have children or school-going children who can help them to upload or download the apps, so it shouldn't be any problem. But the most important, the issues what I face with with the rehab patient, basically, even strokes or traumatic brain injury or other patient, is actually the issue with their phone number, because normally they use prepaid numbers rather than postpaid. So,
prepaid
so
number.
I think,
Okay.
yes. So once they have no credits and they don't have any, they don't have money to top up their prepaid numbers. So that's all.
Yeah.
So I think that's
okay.
the issues that we need to consider, because uploading the mobile apps shouldn't be any problem. But in terms of to sustain their numbers and then to view all those apps, I think it's quite challenges for our patients, basically, in HRPZ.
Yeah.
So this must be considered during, if we want to do our apps for them.
Thank you very much. That's very important. And so other than the prepaid numbers, do you have any other suggestions?
It's quite difficult because most of them, from my experience, they use prepaid numbers. Even if you said, the postpaid numbers for those, many of them have, but I think majority of our patients from the lower social income, they will go with prepaid numbers. So I think it's quite difficult if the cost issues, they have to bear the cost issues lah, basically.
Would you like, in that apps technology, would you like for the caregiver to be able to contact your staff in HRPZ, I don't know what, 24 hours, 7 days a week, to get help from your Ministry of Health staff? Do you think that will be a burden? It will be a waste of time, what do you think? In the state of Kelantan?
I don't think 24 hours is we can cope the 24 hours and every days to just entertain this kind of ni. But normally normally rehab patients from HRPZ, they know they need to contact is either the ward or our clinic, our rehab clinic. They have their numbers, and normally we reschedule their appointment earlier if they really needs to see us. But in terms of someone to be there to 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 be contacted like 24 hours for us is quite difficult because we don't have that many human resource basically.
Even though we make an apps for you in such a way with artificial intelligence and all that, do you think that apps can work in the state of Kelantan? It's like, you open a bank, you go to your bank bank website, and suddenly this AI comes out. Hello, how are you? How can I help you? And that's just for banking, internet banking. So if you had an apps like that, and that's already in Malaysia, all the Malaysian banks have that. So if that is such that, in Bahasa Malaysia or whatever, the guy comes out, hello, how can I help you? And then the guy types in, I have a problem, I have contracture on my right foot, and I need to know what to do with my caregiver, and then the software is able to get the message to a representative in HRPZ, for example. Maybe not immediately 24 hours, but maybe you can answer within 2 to 3 days. Would that be helpful?
It's really helpful, but I don't think like if you want to be responsive 24 hours, we are not able to do it unless if we can collaborate together with HSM rehab people to help. We together with HRPZ and HSM people to collaborate together. That means our human resource is not only HRPZ, but it's also from the HSM too, from the rehab HSM. So it should be, if you have that kind of manpower, I think it should be okay. But if you solely hope on HRPZ, we have, it is beyond of our job scope lah, basically, because
I want to ask a naughty question. In the guys who take care of stroke, range from the internal medicine specialist in Malaysia, the pediatrician, the rehab people, neurosurgeons like me, neurologists, now family medicine specialists in the community, public health specialists in the community. So this is a caregiver app that we're talking about. Do you think the caregiver apps should be under the control of which specialty?
If you're talking about proper rehabilitation, I would say...
Yeah, this is the caregiver app lah. As you said, you present just now, I counted it should be about at least 20 videos or more to teach the caregiver, and now, okay, let's say we made this video, but to make sustainable, who should it be? Because in medicine, we have politics as well.
Yes.
So who should it be under? Can it be under public health? To take care of this technology and the apps?
If you remember my presentation just now, Prof, there's the study in Vietnam. The number 2 is actually the concern of the caregivers about the medication. I think if it's related to the medication, the neurologist, the family medicine specialist can just answer it. It's not per se of the rehabilitation domain. But if they need the proper, like how to take care, how to transfer, how to do the stretching exercise, strengthening exercise, besides rehab medicine specialists or rehab medicine doctors, I think we can involve the physiotherapists or any other like occupational therapists also in these apps. And also, if it's regards to the communication-wise, speech and language problem, we can add on any speech therapist to be with us in this app. So not solely you need the rehab physician in these apps only. Basically, rehabilitation, we have the teams.
Okay. I just want to throw this question to Dr. Iliatha. This is from Tuan Siti and this is maybe looking at past experiences and maybe the UK. He said, if only such mobile app project is supported by local mobile internet network provider companies as well, would it be possible? He said, I believe some internet data providers do give free data for some apps or in some customized data package. And then Nur Faizah says that in the positive way of thinking, I think we need to get used with AI. So just asking Dr. Iliatha, what do you think, Dr. Iliatha? Do you think it would be easier for the apps to work in UK than in Malaysia or even in India?
I think in terms of how apps, in terms of the process of developing an app, I think it's the same whether it's in the UK or in Asia. I think some of the barriers and the difficulties are the same. In terms of free data for apps, I'm not sure what the cost is involved, and also if you're thinking about scaling it, how feasible that is. And then the artificial intelligence, again, that's where there's not much difference which country it is, because you really need to nail down the content of the AI. So for example, if you're having some form of chatbot, and that requires this iterative process in order to get to that end stage.
So this checkbox is quite important, eh?
The end result, to have a chatbot so information is provided automatically, that's ideal, but in order to get that right content and information, you probably do need people working in real time.
So if the gestational diabetes project, do you think the AI will be very helpful in that project, for example?
It will be, but for the project itself, we won't get to that stage of having the AI, because we're using the real-time information. Yeah, I think it is important, but yeah, having that right content is a long process, I think, just from previous experience.
Because the previous experience is very important before we waste time and money and ideas, you know. And again, this is a different culture set, you know, in Malaysia, especially in Northeast Malaysia, and we have to adapt to it, because we cannot have an app that works in Kuala Lumpur but doesn't work in Kota Baru. You know, it will be an unjust world. It has to be an app that can work in rural and district areas. You know, so now I pass over to Kamaru, because we have another 7 more minutes before 5 o'clock. I was informed that we're going to stop at 5 o'clock if that's the idea or not. Maybe Kamaru wants to say a few things.
I just want to say that, you know, just right before we close our session, we're gonna have a photo session. That's what I want to say. Right.
Photo session.
So which might be at 4:58, something like that. You know,
4:58, another 5 more minutes. Okay.
I think we got maybe 3-4 minutes to, you know, if there are burning questions. So
maybe a word or two from the society to make it someone from the society to make it more practical. You know, remember, most of the association AJKs and EXCO are not patients. You know, most of the AJKs and EXCOs of Stroke Society, even in Kelantan, are healthy human beings, because the Kelantan stroke patients are shy to become, you know, even though they have recovered, shy to become EXCO members of societies. So now, when this topic today is about apps technology. So what is the wish list of the society if an apps technology should function in Malaysia?
Yeah, who can answer that?
Okay, apa dia? Ashraf lah, is it?
Dr. Wan Ashraf, you want to answer on behalf of some other Malaysian Stroke Council or the NASAM ke?
Tracy,
What's your wish list?
Basically, like what Prof. Jafri mentioned just now, called the Stroke Society, that's called this professional body that's at the moment is Malaysia Stroke Council, and in fact we created in 2019 we're called as Malaysia Stroke Academy, where it's actually a comprehensive called a team of stroke physician, rehab physician, physiotherapist, overall from stroke care, even emergency physician to IR. So there's such a network called Malaysia Stroke Academy, and called for the stroke support organization, that is our patients called champion, and one of the most important one in Malaysia, because of in Shiraz also we have a different group, and in from what I'm aware is basically they are stroke survivor. So we have NASAM, and now there's already 9 branches in the whole Malaysia. And for example, in 8 branches, sorry, Tracy, very good. So thank you for that. And called in Shiraz, for example, we have Kekasih. So that is called a group of stroke survivor that really called support to each other. But I spoke to Miss Sylvia, I think 2 years back, 3 years back. Then Tracy now just updated us that, for example, just to share, stroke called post-stroke support group, Tracy, right? So there already a helpline. Maybe Tracy, you can just put up the helpline if they need help. So that maybe for the students that are doing the study, if you can project that up in the mobile apps. So that is available. So yeah, 018-222-1878. So that is the wish list that I have when 3 years back. Now it's already there, and I hope that it can be utilized. Yeah, at the moment. But as Prof. Jafri mentioned just now, if at all we want to provide mobile apps, it should be according to our called Malaysia. We have our own tradition, our own attitude towards application, and we have our own difficulties, hurdles. For example, connections, internet connections. So basically, I'm using called a telestroke apps, Prof. So that is for physician to physician. So and because of most of the physicians they know how to really utilize the mobile apps, but to post-stroke care, maybe you need to look into whether it's practical enough for the carer and the patients to basically using the mobile app. So maybe it's a mobile apps but browser method from what I'm using now, and even in the Malaysia Stroke Council you can access it. We call as called My Stroke Hospital called web locator. We use a web browser because we know that not everyone can access through Facebooks and Instagram, everything. So you can just use the web browser method. So, but yeah, look forward for the study method to continue, and we will please present it in our local conference too.
Yeah, thank you, Dr. Wan Ashraf. So I think Kim, 4 o'clock Malaysian time, that ends our interesting seminar, Betterment in Stroke Caregiving during COVID-19 pandemic, from manual to modern apps. And we have heard presentation from Iqbal, from Dr. Daryani, from Dr. Suresh, from Dr. Iliatha, and Ashraf has joined us incognito, and Kim has said a few words. So I think this has been interesting. The information is helpful, especially to me. I can show you the notes that I'm making from all the talks, from Iliatha's talk, Daryani's talk, Iqbal's talk, Suresh's talk. So this is going into my hippocampus now, and that will hopefully help further discussion, Kim, that we're going to have to make sure our apps is useful, especially in the state of Kelantan, and hopefully also in Kuala Lumpur and the rest of Malaysia one day, And let's hope this seminar does help us to move it forward lah. So thank you very much to all the speakers. For those who have not had their breakfast in UK, now you can go out and have your cappuccino or your coffee. And for those in Malaysia, I think it's 5 o'clock and it's raining very heavily outside in Kota Baru, Kelantan. They say it's going to flood in a few more days. So get your scuba diving equipment ready, you know, to get through the floods. So thank you very much, Dr. Kim, for organizing such an important seminar. Thank you, Newton. Thank you, Newton-Ungku, Omar punya grant. Thank you, Dr. Iliatha. Thank you, Suresh, who has left us. Thank you, Iqbal. Thank you also, Dr. Daryani, our next door neighbor, close and yet so far. And Wan Ashraf. Thank you. Bye-bye. Okay. So I think we can leave now. And I don't know how you're going to share the photograph with all the attendees just now.
Right. We're going to share the photograph and we're going to share also the recording. So thank you, everyone. Dato, thank you for sharing the session. Wonderful MC. Thank you. Bye-bye.
Thank you. Thank you. Bye-bye.